Imagine you manage a medical clinic and you just hired a brilliant, highly sought after specialist. Like you are paying their $400,000 salary.
Right.
They have the skills, they're ready to treat patients, and you have this massive waiting list of people desperate to see them.
Yeah, ready to go.
Exactly. But instead of operating on patients, that top-tier specialist is sitting in the break room for 3 months doing absolutely nothing.
Just waiting.
Just waiting. You are paying them, but they cannot generate a single dollar of revenue. And I mean, that is the hidden reality of modern healthcare. It happens every single day.
It really does. It is a massive operational failure
Yeah.
that just sort of hides in plain sight.
Yeah.
Because, most conversations about clinic revenue, they revolve around patient volume or maybe adding new service lines.
More patients, more money.
Right. We focus entirely on the clinical output. But the actual financial mechanics of that clinical work are completely governed by an administrative bottleneck that, honestly, most people outside of practice management never even think about.
Which brings us to our mission for today's deep dive. We are looking at an April 2026 article from Prime Credential, and it's titled, How to Use Credentialing Data to Improve Clinic Revenue.
Good read.
Yeah, it really is. And if you are listening to this, you likely already know the basic definition of credentialing. We are not here to read you a textbook.
No, definitely not.
The goal today is to understand how this notoriously tedious, headache-inducing compliance task can actually be flipped, like turned into a powerful revenue-leveraging tool through analytics.
And that requires a fundamental shift in perspective. You have to stop viewing credentialing as just this static cost of doing business.
Or just a giant pile of paperwork.
Exactly. And you have to start treating it as a strategic, measurable lever that literally controls your cash flow.
Okay, let's unpack this, because to fully grasp how analytics solve the problem, we really have to look at the sheer scale of the failure first.
It's huge.
The source material points out that the financial damage of letting credentialing drag on is just staggering. Until a provider is fully vetted, and until industry databases like CAQH, which, is supposed to be the central clearinghouse for all this provider data.
Supposed to be, yeah.
Right. Until those are actually updated and processed by the payer, revenue completely stalls.
And if a clinic tries to jump the gun,
Oh, man.
if they go ahead and treat patients whose insurance hasn't officially cleared the provider yet, like maybe they just don't want to keep the patient waiting.
Which makes sense clinically, but financially.
It is disastrous financially. Those claims are going to be flat out denied. You are providing the labor, utilizing the clinic's physical resources, and you're receiving zero reimbursement.
Wow.
The text notes this costs clinics thousands of dollars per week in lost billable hours.
Thousands per week. So to understand why this takes so long, we have to look at the mechanism. To me, it is like trying to get into a VIP club. The doctor is fully dressed, highly skilled, ready to work and treat patients, but the bouncer, which is the payer or the credentialing portal, is just taking forever to check their ID.
That's a great way to put it.
And until they get inside that club, no one makes any money.
That captures the friction perfectly.
Yeah.
Because, CAQH was designed to centralize this data, right?
Yeah, the whole point was efficiency.
But the insurance companies still have their own internal, highly manual processes. They still perform what they call primary source verification.
Which sounds fancy, but what does it actually mean?
It literally means an analyst at the insurance company might be required to independently contact a medical school to verify a diploma from 15 years ago.
You're kidding. By hand.
By hand. A phone call or an email. And the clinic has to complete 2 parallel tracks at the same time. There's hospital privileging, which allows the doctor to actually practice in the physical building, and payer enrollment, which guarantees the insurance company will actually pay for the services.
So 2 separate mountains of paperwork.
Yep. And both tracks have to be completed end to end if you want to optimize the revenue cycle. It's not just about money either, it's about patient access.
And the human cost of that archaic system is huge, too. Like, the American Medical Association points out that this manual credentialing is incredibly time-consuming, and it actively distracts clinicians from patient care.
It's demoralizing.
Imagine studying for over a decade to save lives, and then you spend your first 2 months at a new job hunting down, 10-year-old malpractice policy numbers.
I know.
Just to fill out these formatting-specific forms for 20 different insurance companies.
It accelerates burnout before the provider even sees their first patient at the new practice.
Yeah, definitely.
In fact, the source quotes an industry expert who lays out this sort of trifecta of damage. They say delays in credentialing and enrollment can impact revenue, patient access, and provider satisfaction.
So if a clinic is bleeding thousands of dollars a week and doctors are frustrated and patients are stuck on waiting lists, I mean, how is it possible that clinic managers are just throwing up their hands? Why couldn't they see the bottleneck before?
Well, mostly because of an asymmetry of leverage.
What do you mean?
You have these small or mid-sized clinics dealing with massive labyrinthine insurance corporations. When a clinic manager is just dealing with stacks of paper or, static PDFs, a 3-month delay just feels like a vague, persistent headache.
Right, it's just the way it is.
Exactly. They lack the visibility to pinpoint exactly where the application is stuck, so they just accept the delay as the standard cost of doing business in healthcare.
Here's where it gets really interesting.
Yeah.
The Prime Credential article outlines how you break that asymmetry. You move away from just complaining about the system, and you start isolating the variables using data.
That's the turning point.
The very first step is breaking out credentialing performance by individual payers. You measure exactly how slow each specific insurance company is.
You establish vital metrics, and the first one they highlight is cycle time by payer.
Cycle time by payer.
Right. This measures the exact number of days from the moment the application is submitted to the moment approval is officially granted.
The article gives a really concrete comparison for this. Say you look at your new analytics dashboard, right? And you see that Medicare applications are taking an average of 45 days to complete.
Oh, 45 days.
But then you look at a major commercial health plan, and their average is 90 days.
What's fascinating here is the psychology of data visualization.
How so?
Because when you transform an anecdotal feeling like, oh, that one commercial plan always takes forever.
Right, just a gut feeling.
Yeah, when you turn that into a hard metric on a bar chart, those invisible delays suddenly become quantifiable problems. Administrative leaders can actually attack a specific 90-day cycle time. They can investigate the actual mechanics of that specific payer's delay.
And it exposes the specific hurdles. Like, why does the commercial payer take 90 days?
Right. Is it them or is it us?
Exactly. Maybe they have a 14-day internal routing rule before a human analyst even opens the application file. Cycle time makes that visible. And another vital metric they emphasize is time to billing.
Oh, time to billing is crucial. It is the true measure of operational impact.
Break that down for us.
It is the number of days from a provider's official start date at your clinic to the day they are legally eligible to bill for a patient encounter.
Wow.
So if a provider starts on January 1st, but their time to billing is 60 days, you are carrying their overhead and their salary for 2 full months without them generating any offsetting revenue.
That is brutal for a clinic's bottom line.
It really is.
And then there is the metric that I'm sure drives administrative teams completely insane: rejection and rework rates.
Oh, absolutely.
Because this isn't just an application sitting on a desk. This is an application actively getting kicked back to the starting line.
High rejection or rework rates are incredibly revealing, though. The source material explains that these usually stem from missing documents in the initial submission, or provider turnover, or just unfamiliar payer requirements.
Let's look at the mechanics of those rejections, because it is rarely a case of a clinic just forgetting to hit attach on an email.
No, it's way more complex.
It is much more insidious. It's like submitting a document as a standard PDF when that specific payer's obscure rulebook requires a TIFF file.
Yes.
Or perhaps there is a 3-month gap in a provider's employment history from 6 years ago, and one specific payer demands a notarized letter explaining that gap, while the other 19 payers don't care at all.
Right, and without analytics tracking those rejection rates by payer, a clinic might not even realize that their staff is constantly caught in this rework loop with one specific insurance company over these completely obscure formatting rules.
They just think they're bad at paperwork.
Exactly.
Yeah.
But by isolating those high rejection payers with data, a clinic can prioritize follow-up. They can even seek expert help or consultation to get the application perfectly formatted the very first time, which fundamentally minimizes those lost billing days.
Well, identifying the bottleneck is great. I mean, it is certainly nice to know exactly why you are losing money.
Sure.
But for you, listening to this and looking for practical takeaways, identifying the problem is totally useless without action.
Completely agree.
Let's shift our focus to how clinics actually use these specific metrics to recover that lost revenue and optimize their internal workflows.
Right, so we move from reactive reporting to proactive analytics.
Proactive, yeah.
The article emphasizes that deploying dashboards to track enrollment cycle time by payer allows leaders to dynamically allocate their resources.
Like shifting staff around.
Exactly. If your dashboard flags that a specific commercial payer is suddenly spiking to a 100-day delay, you don't just wait it out. You immediately shift more administrative staff to focus purely on escalating applications with that specific payer. Or, you deploy technology to automate the daily status checks.
It is about seeing the traffic jam before you drive into it.
Yes, perfect analogy.
The source talks about tracking pending applications over time to flag backlogs before they cause a cash flow gap.
Right.
You aren't waiting for an end-of-month financial report to tell you revenue is down. You are looking at a dashboard on a Tuesday, you see a pileup of pending applications, and you attack it before it hits the bottom line.
There is a classic business adage quoted in the article, "What gets measured gets improved."
Classic for a reason.
And they back that up with a really compelling real-world case study. So a clinic implemented these analytics, and they discovered that one specific insurer was taking twice as long as all the others to approve providers.
Okay, so armed with that data, they took highly targeted action, right?
Yeah.
They streamlined their internal application process for that specific insurer to ensure zero formatting errors, and then they escalated the issue directly with the insurer's management.
And the result?
As a result, they accelerated their billing eligibility and cut their overall credentialing time by 30%.
A 30% reduction is a massive operational victory.
Huge.
I mean, that represents weeks of billable hours recovered for every single provider that clinic hires from that point forward. It fundamentally alters their revenue trajectory.
It also allows teams to engineer the friction out of specific choke points. We talked about primary source verification earlier.
Annual phone calls.
Right, the manual process of verifying medical school history or past hospital privileges. If the data shows that this specific stage is where your applications consistently stall, the credentialing team can proactively automate that step.
Yep.
They can verify that specific data up front, internally, before even submitting the package to the payer.
And this is exactly where Prime Credentials positions their specific solutions. They aren't just handing you a spreadsheet.
No, it's way more integrated.
They provide real-time dashboards to surface these pair-specific delays, and crucially, they integrate the credentialing data directly with the clinic's billing systems.
That integration piece is vital because in a lot of clinics, the credentialing department and the billing department operate in total silos.
Like they don't even talk to each other.
Right. The credentialing team finally gets the approval, but the billing team doesn't know, so claims still aren't going out.
Which is maddening.
But by integrating the systems, the moment a provider is cleared by the payer, the billing system is automatically updated to release their claims.
It creates a completely seamless flow of data. And Prime Credential also offers expert consultation to actively reduce those claim denials we discussed earlier.
Making sure all the TIFF files and PDFs are right.
Exactly, ensuring the formatting and documentation meet the idiosyncratic demands of every single pair. And the ROI timeline for implementing this, the return on investment, is remarkably fast.
Yeah, looking at the FAQs in the text, they note that addressing even a few days of delay pays off immediately. We aren't talking about a massive enterprise software implementation that takes 3 years to show value.
No, not at all.
Within weeks, clinics see increased billable claims and a sharp reduction in write-offs. And they make a point to note this applies to small practices just as much as large, sprawling health systems.
Honestly, it's even more important for the small ones.
Because a small practice simply cannot afford to have a doctor sitting idle for 3 months.
Exactly. The smaller the practice, the more critical the cash flow disruption is. A large hospital, they can absorb a 90-day delay for one specialist. A private practice with 3 doctors. They might struggle to make payroll if their newest hire can't bill for a quarter of a year.
Okay, I am going to interrupt this tech utopia narrative for a second. We are talking about dashboards and API integrations and real-time alerts, but does adding a real-time dashboard actually fix the slow insurance company?
Fair question.
Because a dashboard doesn't magically make an insurance representative process paperwork faster. It seems like it just gives the clinic manager a really high-definition, color-coded view of exactly how terrible that insurance company is at their job. You still have to deal with their archaic processes.
If we connect this to the bigger picture, you are right that a software dashboard cannot force an insurance analyst to type faster. But confusing visibility with resolution is a common trap.
Okay.
What the data actually gives the clinic is leverage.
Leverage against a multi-billion-dollar insurance company.
Absolutely. Think about the power dynamic without data. A clinic manager calls an insurance company to complain about a delay.
Right.
The insurer's representative can just read from a script and say, "We are experiencing standard processing times."
Basically telling you to go away.
Exactly. It is one stressed administrator's word against a massive corporation. The conversation ends there.
But with the analytics.
With the analytics, that same clinic manager doesn't call the frontline representative. They escalate the issue to a regional director of network management at the insurance company and say, I have hard data pulled directly from our integrated systems showing you are averaging 90 days for credentialing, while your top 3 direct competitors are averaging 45 days.
Oh, wow.
By moving at half the speed of the market, you are artificially restricting patient access to our clinic.
That is a very different conversation.
Data provides the undeniable proof needed to force a conversation and demand a dedicated escalation path.
It removes the guesswork and strips away the excuses. You're literally bringing receipts to the argument.
And internally, it allows the clinic to shift their own resources intelligently. Like if you know Payer X is incredibly slow and kicks back applications for the slightest typo, you stop applying your standard automated procedures to them.
You handle them with kid gloves?
Exactly. You assign your most meticulous, experienced staff member to aggressively manage Payer X applications from day one. You proactively call them every 48 hours. It fundamentally changes credentialing from being a passive revenue risk, where you are just crossing your fingers and hoping the approval letter arrives in the mail, into a proactive source of strategic insight.
So what does this all mean?
Well,
If we zoom out and look at the entire landscape we have covered today, the ultimate takeaway for you is that in 2026, healthcare compliance simply doesn't have to be a black hole for administrative time and lost revenue.
it really doesn't.
For decades, clinics just accepted that onboarding a new doctor meant weeks or months of financial limbo. But with the right analytics, by measuring cycle times, tracking rejection rates, integrating your billing systems, and visualizing the specific bottlenecks, credentialing becomes an actionable revenue opportunity.
Yes.
You aren't just pushing paper. You are actively optimizing the cash flow of the entire practice and leveling the playing field with massive insurance payers.
It is a complete paradigm shift for healthcare administration. But, this raises an important question, one that extends slightly beyond what Prime Credential is doing today, but represents the logical next step for this kind of data transparency.
Okay, where does this transparency naturally lead?
Right now, these analytics are being used internally by clinics to hold insurance companies accountable and accelerate their own revenue cycles.
Right.
But if data analytics can give clinics this much high-definition transparency into exactly which insurance companies are dragging their feet, could we eventually see a world where patients gain access to similar data?
Think about that.
Imagine if, during open enrollment, you as a patient could use a dashboard to choose your health insurance plan. And instead of just looking at premiums, deductibles, and a static list of in-network doctors, you could see a payer friction score.
A payer friction score. I like that.
You could actually look at the data and see that one specific insurance company is known to needlessly delay credentialing for months, actively preventing their network from adding new doctors and creating massive waiting lists for care.
That would completely upend how people buy insurance. I mean, if you know a specific payer uses archaic verification methods that keep doctors out of the exam room, you would actively avoid them. You would choose a payer that actually facilitates fast, efficient access to care.
It would force payers to compete not just on cost, but on administrative efficiency and true network accessibility.
Yeah.
Transparency has a way of spreading, and once this kind of operational data exists, it rarely stays confined to the back office forever.
Uncovering the mechanics of one hidden system can ripple out and change the entire industry. Thank you for joining us on this deep dive into the hidden world of healthcare credentialing and analytics. Keep questioning the administrative systems that operate behind the scenes. Keep looking for the bottlenecks in your own workflows, and we will catch you on the next deep dive.